All right, again, let's take two or take three. Good morning, everyone. This is Dr. Garais, MED240, February 11th, 2021. For those of you who took the midterm, you will see results, and your midterm results were sent this morning for your perusal. If you didn't see it or didn't get something, shoot me an email after class. What is due today? If we look at, nothing's due today because it's midterm. So this week we're going to start anesthetics, analgesics, and narcotics. We learned a little bit of narcotics. What's due next week, of course, is discussion 6 and quiz. And guys, if you didn't score very well on your quiz, I believe I took off the retakes. I enabled the retakes. So try to retake the exam to get the best score possible. Okay. I'm okay with you retaking quizzes so that you can get the best score possible, because it's kind of like training, so that to help you memorize common questions. And oh, by the way, Dr. Cisco made these quizzes. She has a doctorate in pharmacology, and also, I believe, you can't quote me on it, she helped design questions for the registry for pharmacology. So she did something like that, either that or an HA question maker, something to that effect. So these study questions are really neat. So let's jump right in. Now, what's an anesthetic? What's a narcotic? Well, anesthesia, if you remember your medical terminology, IA, state or condition, and no or not, aesthesi means feeling. So when we have to do some bad things to you, like surgery, you do not want to feel any of that. And also pain, which is, narcotics, that's a very, very addictive medication. That's why FDA doesn't monitor it. The DEA does. They're controlled substances. And a survey done a couple of years ago, the Department of Anesthesiology is most likely a department where there is lots of potential for abuse. If you've ever seen an anesthesiologist walk around, multiple physicians walk around with this little tackle box. Well, that tackle box is full of happy drugs. But the problem is, all of those drugs are mostly Schedule 2 DEA controlled substances, and pick up my phone. And they have a high potential for addiction. So how do they work? Well, our nervous system, that's the system that communicates with us, and communicates with us via electricity, right? And chemical. So it's electrochemical communication. And what anesthetics and narcotics do, they can block this activity. And how do they do it? Right? So if you recall, let me make these bigger if I can. If you recall your anatomy and physiology, the electrical signal action potential runs through the neuron here, right? Comes through the dendrites, go through this body, and then jumps through saltatory conduction through through the axon right here. Now, when it gets to the end terminal buds, it signals release of these chemicals, and these chemicals are called neurotransmitters. So let's say, for example, this particular neurotransmitter is something like dopamine, and dopamine has been definitely linked to mood and to good mood. So what would happen if I didn't have enough neurotransmitter? Then I'd be in a bad mood or a depressed mood. But let's say I have a whole bunch of neurotransmitter, right, activating all of this, that will propagate an action potential and a signal in the next neuron, right, or nerve cell. If I had a whole bunch of chemical in here, like dopamine, then it will make me super happy, okay? And dopamine is just one of the several neurotransmitters that have been identified that has a definite link to mood. So if let's say, for example, I don't have enough dopamine, don't you think I can have drugs that will either mimic dopamine or have synergistic capabilities to upgrade my dopamine? Sure. Or let's say I'm manic and I got, like in the case of a bipolar patient where they're having sex every day, they're maxing out their charge account, and you see these people because of their mania, they do drugs even though they don't they're super happy, don't need to do drugs. And that's one of the horrible parts of bipolar is that extreme levels of behavior. Well, do you think I could block this receptor and then it'll have calming effects so that the person wouldn't be so hyped up to be so manic? So that's essentially how a lot of the psychotropic drugs, psycho meaning mind, and your not neurotransmitters, anesthetics and narcotics do. Because let's say, for example, this is the neurotransmitter telling me to signal the body for pain. Well, I could take something and I could block these, and then I will also hence block the pain. Little quick review of your divisions of the nervous center. You have your central nervous system, of course, peripheral nervous system. And the important part of the peripheral nervous system is what we always know of the autonomic nervous system. Now, what's the difference between autonomic and somatic? Autonomic is auto, self. They are involuntary. If you remember sympathetic nervous system versus parasympathetic nervous system. If you remember cocaine versus weed, right? Sympathetic versus parasympathetic. If you recall fight or flight, which was the sympathetic nervous system, and feed or breed, which is the parasympathetic nervous system. And it has involuntary respiration, circulation, digestion, body temperature, metabolism effects. And if you remember fight or flight, it's easy. And here is a, can I make this thing larger? Okay. So if you remember the sympathetic nervous system, think fight or flight. Think, so if I have a drug like cocaine, right, it's going to go in there and it's going to activate the sympathetic nervous system. What will it do for you? It'll dilate your pupils. It'll stop all of your GI, because when you're scared or when you're in a fight, do you think you're thinking about eating a ham sandwich? No, you'll be focusing on what? The fight or flight stimulus. And then everything else should be upgraded: dilated bronchioles, increased heart rate, increased respiratory rate, right? But all the GI stuff should be decreased. And the parasympathetic is, of course, the exact opposite. Here we have these neurotransmitters. These are neurotransmitters that work on your peripheral nervous system. Here are neurotransmitters that work on your central nervous system. So you have acetylcholine, GABA, which is a typical, what do you call that? I don't want to use the word depressant, but it tends to block things. And that's gamma aminobutyric acid. Dopamine, norepinephrine, we all know and love norepinephrine and epinephrine. They are closely associated with things like amphetamines, things like cocaine, all the illicit, the popular illicit drugs such as heroin, cocaine, and that kind of thing. Serotonin, or also known as 5-HT, and glutamic acid, glutamate. Glutamate also is, maybe you might know it as MSG, right? That's why when you have salts with MSG in it, it tends to excite the central nervous system, especially in the realm of eating and your gastrointestinal tract. And it also explains some of the reasons why when you eat Chinese food, maybe you eat too much of it, and you go to, like, I don't know, some shady place, you get a headache, and then you're hungry, even after you've eaten a whole bunch of stuff. That's why FDA is trying to curtail the use of MSG and glutamic acid derivative salts and those things. Sympathetic, parasympathetic, sympathetic nervous system, acetylcholine, norepinephrine, dopamine, epinephrine. And norepinephrine and epinephrine is closely related to fight or flight. So is it any wonder that that is the behavior? If you're on cocaine or you're on heroin, that is the behavior. Okay, and parasympathetic nervous system, acetylcholine also affects the parasympathetic nervous system. So any drug that's an acetylcholine derivative is going to have what? Two sets of side effects. Okay, so acetylcholine, right, works on smooth and cardiac muscle, and we have these set of drugs that block acetylcholine. There sometimes I want to block the parasympathetic nervous system, especially in remember parasympathetic nervous system is feed or breed, right? Sometimes I use those medications in pre-surgical, because do you think I want any of the GI to be active during surgery? Nope, I don't want that. GABA, I mentioned, it is an inhibitory neurotransmitter. Okay, it likes to turn things off. That's why gabapentin, which is a very popular drug for anti-seizure medication. Because what's a seizure? It's uncontrolled electricity in your brain, and then you start convulsing. So wouldn't it be neat if I gave you some gabapentin, and then I inhibited all of that extra neurotransmitter activity? They're now even using GABA for some antipsychotic and antidepressant meds as well. And you'll see that when we talk about psychotropic and psychiatric meds, uh, on different doses, different kinds of drugs will have same mechanism of action, but we're looking at different effects. And a classic is GABA, where in one moment it's used as an anti-seizure medication, and then in other moments it's used for antidepressive, antipsychotic, because what does it do? It inhibits things, right? If you're a psycho, what would I want to do? I want to inhibit any psychopathic of tendencies. Okay, dopamine, epinephrine, and norepinephrine, and we know epinephrine and norepinephrine. We know how it works on the heart. We also know how it's all about fight or flight, adrenaline, and that's why people love cocaine. That's why people love heroin, because that rush. Uh, um, and but my thing is, you could get this rush other ways. Those of you who had me in other classes, I always talk about how I have a fear of heights. Then why every summer I go on roller coasters? Because I fear heights, but I love that rush. I love that feeling of being scared. I also love watching people get scared. My new thing now is I've already done bungee cord to death, so I always get scared and I jumped. But I want to see my wife do it. I want to watch her have a heart attack. It's pretty funny to me. I don't know. I have quite a sixth sense of humor sometimes. Now, but now dopamine. Dopamine is big on memory, learning, attention, sleep, inhibition, and also, do you see all these things here? If you are in a depressive state, you don't have enough dopamine. How's your memory, right? How do you learn? And then you start getting into what? Different addictions. So it's one of those chicken before the egg came. You know, which came first, the mental stuff or the addiction stuff? It's a pretty tough nut to crack. But you could see it has a lot of effects. Little side note: a lot of people take antidepressant medication that works on the dopamine receptors and dopamine neurotransmitter activity. About 10 years ago, a lovely study came out by the College of what do you call it? Sports medicine. And something like some ridiculous number, 250, 300 million people are on antidepressant medication, some ridiculous number here in the United States. And they found out that, you know, that adage where, for those of you who are fellow gym rats, such as myself, like even if you've had a bad workout, there's no such thing as a bad workout. You always leave the gym with like at least some sense of accomplishment, right? So and part of that is because, you know, you worked out. Well, part of it is because when your body works out, it releases these things: dopamine, epinephrine, and norepinephrine. Right? You get a little bit excited when, especially when you're doing a physical activity that's a little bit exciting. Like the other day, my daughter had I give boxing lessons to my daughter. She really gets, you know, she starts off the boxing lesson like, oh, do I have to? And then by the end of the lesson, you know, she gets really into it. So that releases what? Fight or flight, epinephrine, norepinephrine. And then what does it do? Also release dopamine. So if she's having a bad day, you know, her mom was getting on her case, her teacher's getting on her case, she takes it out on that bag. She takes it out on that treadmill. And then after the workout's over, she feels great about it. Right? So you can see how behavior modification, even diet, also affects neurotransmitters. Serotonin and glutamic acid. I already talked a little bit about glutamic acid. Also, there are some studies regarding that it may or may not be related to learning and memory, and also some links to like vitamin B complex related to learning and memory. But the studies that I've read, it's inconclusive at this time. I'll read up some more, but the last couple of studies from the last couple of years, I didn't find any real evidence of this. But definitely serotonin, smooth muscle and gastric mucosa, vasoconstriction, decreased blood flow. But serotonin is also linked, maybe they're going to talk about it. No, they're not. Serotonin 5-HT is also related to dreams and dream states. I worked, I always say 1 or 2 years, but my goodness, it's been like 8. I'm going to give him a call. A doctor, a local doctor here. He is a research scientist, um, um, and his specialty, Dr. Zalaya's specialty. I'm trying to get in on his paper. Hopefully, I'll get published as well if he gets published. He's working on this stuff called lucid dreaming, which is like, didn't you ever have a really great dream that you want to relive? Or you want to be able to control your dreams, especially if it's a nightmare. You know, Freddy Krueger's at the, you know, it's coming after you. You want to be able to, you know, to mitigate that. And it has some lovely applications, lucid dreaming and research of serotonin and its effects on dreams, um, especially for people who have PTSD, and people who want to control their dreams, because dreams are unconscious thought. So, and serotonin is a part of that. And there's some really nice um, research regarding serotonin and sleep cycles. Receptors, alpha, beta. Now, why do you need to do this? Because we have blood pressure medication that works on these receptors. And maybe you've heard of beta blockers. And a beta blocker, right, is if your heart rate is really fast, I give you a beta blocker, it's going to slow it down. And if that slows it down, it will have some mild hypotensive effects. And that's why beta blockers are a good first line drug for essential or primary hypertension. You could have an alpha agonist or alpha, if alpha receptors perform vasoconstriction. So if I have an alpha blocker, it will lower my blood pressure. And lungs, right? Beta causes vasodilatation. So if I have a beta agonist, I can, I use these beta agonists for my asthma patients. So it'll dilate their blood flow, right? Increases you know, capillary exchange of oxygen and carbon dioxide, and it'll open up those constricting smooth muscles on my bronchioles. So you could see how knowing what receptors do what, we can either block them or enhance them depending on what kind of effect do we want, right? And here's beta block, beta 1 and beta 2. Nice to know. This is should know, must know types of receptors. So we already know there's the agonist and the antagonist. You could either enhance something or block something. And one of those things that we like to do, remember the cholinergics were good for uh, what do you call that? Parasympathetic. So if I gave you an anticholinergic, what will it do? Right? Because it will have a whole bunch of peripheral nervous system slash GI effects. Right? This is good to know, and that's why. How's this? This is must know anticholinergic. Dr. Cisco wrote it in red. And it's really important because there are other drugs that have anticholinergic effects. Anesthetic. Now, you can either have a general one, which will affect your entire central nervous system. Those are the ones we get a little bit excited about. Well, at least the Department of Internal Medicine and the Department of Anesthesiology. Department of Surgery, not so much. That's my little dig against all my surgical compatriots out there. You either have general or local. So for example, if I need some stitches in my hand, I'll use something called a hand block. It'll only block the pain in that area. But if I give you a general anesthesia, something like a gas, like halothane, we have anesthesia from head to toe, right? So that's everything. But if you have something like general, there's a lot of potential side effects, and there's a lot of bioavailability issues, meaning to say is, especially a lot of the gas anesthesias, they tend to hide in fat. So if you're a little bit chunky, such as myself, join the chunky club, also known as Doritos Anonymous, some of that gas is going to go in that fat, and then we're going to have a hard time bringing you out of that anesthesia. Okay. And that's why anesthetic drugs, we are really careful, especially with anything that's gas or vapor. But the local, like a leg block, foot block, hand block, those are nice, right? They have limited effects and they're only in the local area. But any gas, you have these reversible actions, but sometimes if the gas stays in there too long, it gets really hard to reverse these things, especially this top part. Post-op is the responsibility of internal medicine, not surgery. So it is my job and anesthesia's job for when the patient's having a hard time coming out of their anesthesia. Sometimes they code too, which is not fun. Amnesia on recovery. There have been several times in my career where the patient woke up in the middle of surgery, but when we got them in post-op, you're like, "Hey, Mrs. Jones, scared us a little bit. You woke up in your surgery." She's like, "I don't remember that," because we combine anesthetics with amnesiacs, or drugs that will help you forget, because you don't want to remember any of that pain. You don't want to remember getting up in the middle of it. You don't want to remember any of that process. Okay. Skeletal muscle relaxation. That's why many times we put you on mechanical ventilators so we can control everything. Okay. We have pre-anesthetic medication. So before we put you under, I got to sedate you. I have to reduce post-operative pain. That's a biggie. It's a balance because I don't want to make you an addict, but I also don't want you to suffer severely. And those of you who are thinking about having a mammoplasty or a nose job or any of that thing, the level of pain, especially with tummy tucks, the level of pain, even I put them on max dose and they're still begging me to put some more stuff. Again, I'm not a proponent of elective surgery. Only get cut when you really, really have to. But getting cut because you want a cuter nose or a nicer butt, or you want people to look at your chest instead of your eyes, really, really not advisable medically. So we use benzos. Benzodiazepine. They're typically used for anti-anxiety, right? We also use antiemetics because I don't want you to vomit, okay? and also anticholinergics because I don't want any GI effects while you're under. So why an antiemetic? Why do I don't want you to vomit? Why the anticholinergics? Because if you vomit while you are, whoopsies, how do I get that back? What happened? What happened? Okay. I probably have now 2 copies of this bad boy now. Where am I? So if my patient vomits while there's skeletal muscle relaxation, that means some of that vomitus might end up in their lungs. And that will give a situation called aspirational or aspirational pneumonia. And that's very hard to treat. Some patients may even die if they have a lot of comorbidities. So when we say to the patient, NPO, we mean it. Not because there are times like not even water, especially if I have you on a drip for saline, you don't eat anything, non per orum, nothing by mouth, nothing. How many times like, well, I ate a little piece of chicken. We're all looking at each other. We have to now move the surgery because that little bit, if it comes up, it's just not fun. So general anesthetic. This is a common trivia question for general anesthetic. A very serious side effect is malignant hypothermia. We won't be able to control because it messes with your brain. And who controls your temperature? Your brain. So you get malignant hypothermia, we give them dantrolene, right? Because fever of like 106 degrees and more will have seizures and brain damage. Now, here's some of the inhalants, which are really popular, and you see the suffix ANE, and of course nitrous for all you party people, right? Laughing gas, right? By the way, if I'm putting all of these things in your lungs, don't you think some of this might push out oxygen? That's why having nitrous at a party, not a good idea. I remember my first year in EMS, my rookie year, we got called to a party where this kid passed out and then fell down the stairs onto a glass table. Don't ask me how, but he was doing nitrous, right? Also known as zippets, also known as, what else do they call it? But it will push out other gases, and then he kind of self-asphyxiated himself, then he passed out. And of course, what happened, he's in the hospital for a couple of days because of no oxygen to his brain for greater than 5 minutes. He had a little bit of brain damage, and at the ripe old age of 20 had some signs and symptoms of a stroke. Which, by the way, fast forward, he was a scholarship at some local college in New York City. He was on a scholarship, lost his ride because of the brain damage. Because remember, when you're on scholarship for sports, you have to be cleared medically every season, and he had a stroke. So how can you get cleared medically? Lost his ride, lost everything just because he wants to be funny at a party. Characteristics of inhalants, you don't need to know this. Just know that the inhalants, they could push out oxygen, and then there are the overall other side effects, which reduction of blood pressure and reduction of renal functioning, and the all dreaded nausea and vomiting. Okay, so it drops the blood pressure and drops the renal function. So that's why we catheter you immediately, and we also, the anesthesiologist is also looking at your heart rate and blood pressure the entire time of before, during, and after the surgery. Because like I said, inhalant or systemic anesthetics will affect a broad spectrum of things, but the number one, number two is blood pressure, and it'll drop your renal function. Nitrous has analgesics effects, which is really nice. Desflurane, and all of these inhalants, they're all volatile. Meaning to say is they like if you release them into the air, they'll dissipate real quick. You also have some injectables. We like doing it via IV drip so we can control it, right? And again, the stuff, once I do IV, that means it's what? Systemic. It gets real dangerous. Here's some examples of injectables. And looky here, morphine. And if anyone ever had a morphine drip, I call it the happy curtain. I've been in surgery and emergency rooms more time than I care to remember in my youth. And once or twice I got morphine, and it felt like this warm, beautiful curtain. And I do not condone drug addiction and drug abuse, but I can fully understand how someone can get hooked on it. And here's another one: ketamine. It's a class 1 drug. We actually use it for things. Ketamine has this horrible, horrible side effect called dissociative amnesia. And I always tell this story regarding ketamine. We had a 16-year-old and a 19-year-old come in, and they were going to a rave, and they were putting ketamine droplets into their eyeballs. Well, being 16, being 19, you probably don't have a degree in pharmacology yet. Didn't know what kind of dose. Well, the 19-year-old, when he woke up handcuffed to his bed, and he was wondering why the cops. He goes, "Am I in trouble? Is it because I bought some K?" And I'm like, "No, it's a little bit more than that." And he goes, "I had the weirdest dream, doc. I had a dream that I was stabbing my girlfriend." And he was like, "Where's my girlfriend?" And then I told him, "I can't talk to you about that." Well, the one thing that I couldn't talk to him about, it wasn't a dream. Those two were high behind some dumpster, behind some random club in New York City. He took a knife. I don't know where he got it from, and stabbed the girlfriend 19 times in the chest. 16-year-old, she died, of course, and he is now going to jail for a very long time because of the dissociative amnesia. He thought that it was just a dream. He goes, "No, it wasn't me. I was watching it. I saw this guy," and he goes, I don't think it was." And the whole entire time he's screaming that it wasn't me. And it was him. So, hey, taking illicit drugs or taking drugs that aren't meant for what it's supposed to, right? Now, ketamine, we use it for what? Ketamine's originally a horse tranquilizer, for heaven's sake. Something that puts down a horse. Why would you want to put that in your eyeball? But kids will be kids. Barbiturates, Barbies, oh, they're fun, right? And you see that TAL, right? And these are depressants because I want to sedate, I want to relax, I want to depress people. And the most common benzo is the lovely Valium, also known as diazepam. And we love giving that to sedate the patient, as it's a very popular pre-surgical drug. Lorazepam too, midazolam, and you can see they're all Pam and Lambs, Versed, Ativan, and of course, party people will be party people, right? You can see this, especially Ativan, you can see that in any party. So I'm told. Propofol, Diprovan, right? It's used for anesthesia, sedation, treatment of agitation. So the doctor who killed Michael Jackson, why in heaven's name are you giving propofol? When I heard of that, I'm like, wow, MJ must have been off his rocker at the end. And the doctor who did not only did this to Michael Jackson, he did it to several other people. He made his living. I have no idea how the DEA didn't pick him up. But I guess because, you're a Hollywood, doctor, and you got a lot of clout or whatever. I subscribe a couple of extra pills. DEA calls my chain of command that afternoon. And also nowadays, compared to around the time where, around Michael Jackson's death, the DEA didn't have electronic medical records on their side. So now, anytime a doctor prescribes any of these level 1 drugs, I'm not level 1, class class 2 controlled substance. DEA gets informed about it. There's a red flag, and someone will see it. Fentanyl, right? Use this. Open heart. This is nice. We talked about benzos. Right now, what happens if my patient overdoses? Went to the party, took too much of this stuff, too much of anything that activates norepinephrine or epinephrine? Well, I can give one of two things: flumazenil and naloxone. I love Narcan. Narcan is almost instantaneous. They wake up real fast, right? And this is one of our emergency meds that is always in every crash cart here in lovely America. We also have neuromuscular blocking agents, muscle relaxants, right? And because, when you get older, or especially if you have like injuries and things like that, when you're in bed a long time or you're not mobile, you start having like spasms and muscle contractions. So having a neuromuscular blocking agents are nice. You have short, long, and extended. Don't need to memorize it, but if you look at here, EM, curium, because these are derivatives of curare. And if you've ever like watched old timey movies, like when they're, they have like a blow dart and it made you like paralyzed. Well, that's what this stuff is a derivative of. And succinylcholine is a derivative of acetylcholine, which is, we already know, has cholinergic agents and muscular blocking agents. So if you see curium, pancronium, and curium, that is a neuromuscular blocking agent, and it is part and parcel of the anticholinergic family. Okay. Yeah, some people call it Sux or Suxy, succinylcholine, and it's really neat because if you're having a really really bad like spasms and there's this stuff called contractures, not contractions, but a contracture. It's a very, very painful muscle spasm, especially if you're bedridden. Oh, one time I hurt my back and I had to lie in bed on a traction plate for like, I don't know, I've heard it was like 10 days or something like that. The cramps and it's like the Charlie horses that I used to get were horrible until, they gave me some of these. And succinylcholine is real short acting. It'll only be good for a quarter of your day. Neuromuscular blocking agents, local anesthesia. Let's look at other forms of anesthesia. It could be a topical spray, like we have a topical epinephrine for when we do some throat examinations, especially if I have to stick a probe so that you won't have a gag reflex. Epidurals are nice, right? Regional anesthesia. Spinal block, right, is nice for pain states. And if you look at the local anesthetic, like bupivacaine, lidocaine, epinephrine, all of these, you'll see cane because it is a cocaine derivative. It's part of that family. Okay, so you have amides and esters, and those are local anesthetics, like your hand blocks. I love lidocaine, epinephrine, and I love lidocaine epi, which is this little combo here, because it not only has a localized anesthesia, the epinephrine also has a localized vasoconstriction, so that my patient, when I'm sewing them up and stuff like that, it doesn't promote bleeding, which is nice, especially if you're doing little minor surgery. Pain management. Now, who's in charge of pain management? The lovely Department of Anesthesia. They do pain management. Okay, and pain is also known. Maybe you've heard this. It's the fifth vital sign, and if you've been in my MED140 class, you know there is the PQRST of pain. So review that if you don't know what that is. So you could have acute or chronic, right? So acute pain we treat a certain way, and chronic pain we treat also a certain way. Now we also have to look at our patient in a holistic manner, because those of us who have chronic pain states know that there's a point where, like for example myself, like if it's not my foot, it's my knee. If it's not my right knee, it's my left knee. If it's not my knee, now it's my carpal, right? If it's not that, it's migraines. After a while you start going, man, I don't want to. You start having these sad thoughts like, man, I don't want to try anymore. Well, that's a consideration, especially with chronic pain states for our patient, because that'll wear on a person. Imagine being pain like every day. It's not it'll wear down on you. It'll wear down on the strongest person. Now, if your pain source is somatic, body, right? Uh, you can use narcotics, but all of us love NSAIDs, non-steroidal anti-inflammatory drugs, such as Tylenol, also known as acetaminophen, right? Because it's non-toxic and it'll get the job done. But narcotics, we have to be careful because that is a level 2 controlled substance, and there is a very, very strong potential for addiction. That's why when I don't go to the dentist, so every 10 years I have to have oral surgery. Yeah, I'm one of those people, right? They give me a bunch of narcotics. You know what? I just man up and just deal with it and just live through the pain, not sleep for a couple of days, because I don't like the side effects. And the side effects of a lot of narcotics is GI and vomiting and nausea. I really hate morphine. Um, like even days after a morphine drip, I'm like, I love it in as it's happening to you, but when you're coming down from it, it's just not good. You could also have visceral pain, right? And again, I guess I like NSAIDs because they're non-toxic relatively compared to nerve blockers and narcotics. You could also have neuropathic pain. Neuropathic, neuro means nerves. The source could be a nerve. I always talk about this one patient. I had a patient. He was kind of like a country, like mountain man kind of thing. And his daughter, who lived in New York City, brought him in because he lived in upstate New York, and he kept on every couple of months or so because of he had some severe tooth pain. And then they brought him to me to evaluate in the ER before we send him to uh, not only dental, because it was a dental emergency. Um, he kept on pulling out his teeth to the point where he was a man in his mid 60s, only had like 2 or 3 teeth in his head because he kept on pulling out teeth. Now, what we found was he had neuropathic pain. He had trigeminal neuralgia. So it presents like jaw and teeth pain. And every time he'd pull out a tooth, he thought he thought, that that would do the trick. And he was doing this for years. But we eventually got him. Once we diagnosed it, well, not me, but I knew it wasn't tooth pain. So I called off the dentist, called the neurologist, and they found it was trigeminal neuralgia, right? And then once we gave him what do you call that? We gave him a form of gabapentin, which also works as an anticonvulsant. And it worked on his nerve, and he stopped pulling his teeth out. And you could see how an anticonvulsant, usually for anti-seizure meds, can also be used for neuropathic pain. Antidepressants can also be used for neuropathic pain. You could have an overactive sympathetic nervous system. And if you have an overactive sympathetic nervous system, we're going to start also looking at some psychiatric issues as well. Anxiety states. because all of us know, like when you're anxious, don't you get headaches and you feel bad, and those are side effects of your sympathetic nervous system. Um, Opiates, again, level 2, very dangerous, right? Once because the funny thing about these opioid receptor sites, after a while, they'll like the drug better than they like the neurotransmitter. The affinity for the drug supersedes the affinity for the natural neurotransmitter. That's why when you take a hit of the pipe for crack cocaine, you'll get addicted almost instantly, because the affinity for the variant of the crack cocaine variant versus regular cocaine is like, I don't know, it's to the 10th power. It's just some ridiculous thing. That's why in the 80s and 90s, when crack ruled New York City, it was so it was like creating a zombie nation. It was kind of that. It was that scary. So we like narcotics. Has analgesia. We already showed that. Sedation. It can it can sedate you, and it feels good. But sometimes, if you're not used to being high, right, you'll have dysphoria, right? Euphoria is that feeling of well-being, and especially when you had a couple of beers in you. Oh, you're my buddy, you're my friend. And then what happens? The bad trip comes, and then you don't love me. And then you guys know, you guys been to bars, right? You know the whole scale. But you could see how the effects of narcotics, their initial effects could be then reversed for regarding prolonged abuse. And the potential for addiction is that the receptor sites will start upgrading, meaning to say is it's going to need more drug to get the same high. And that's why, they start off, oh, my occasional, I do a bump of cocaine or whatever. Then they start doing crack. Then they start doing these other things, right? I believe in the data that, things like marijuana and the so-called lesser drugs are not gateway drugs. That's what the current data suggests. It's not gateway drugs. So if you smoke weed, it doesn't necessarily mean you're going to be, you're going to be doing meth next month. But there is also data that suggests that if you already have an addictive personality, no matter what you're going to touch, weed or whatever, it's going to get worse. Um, uh, I have some friends who, like, they cannot live without their marijuana. They are functional with the marijuana, and they get very depressed without the marijuana. That's a little bit scary because marijuana, data wise, because it doesn't have the affinity of THC, or the active ingredient of marijuana, which is tetrahydrocannabinol, is nowhere near cocaine. But then why do I anecdotally have these patients, and I have these family and have these friends who they wake up in the morning, they need it. And it's really interesting to watch how some people have a predisposition to hardcore addiction, and others who don't. I had a friend in college. She was just like me. We smoked since we were 12, and we were already in our 20s when we were in college. And she quit like in a day. It took me 3 years to quit smoking, and she quit in a day. She got pneumonia, and then she came back. She goes, "Here, you want a pack of my cigarettes?" And I'm like, "Yeah, what's up?" And I go, "You found Jesus?" And she was like, "Goes, no, I just want to smoke anymore, because I don't want to have that. I don't want to be sick anymore." And I just talked to her on Facebook the other day, and I go, "Hey, Shell, you smoke?" And he goes, "Nope." And he goes, "You?" And I go, "Sometimes." Right? So remember, there is a genetic component, which definitely the Garais male genetic component means you are a smoker, you are a drinker. Analgesic ladder of pain relief, right? Mild to moderate pain. I actually, on mild pain, I just ask the patient, try it. Try just living with the pain, and working through the pain, because I don't like them. I don't even like putting them on anything, right? Sometimes when we need a little bit more, we use like acetaminophen with codeine, and maybe you've heard of it. They're called Tylenol 3, Tylenol 5, Tylenol 6. and the higher the number, the more the codeine. This is nice for like like dental stuff. But here in Virginia, they went straight to Percocet with me, and I'm like, what? And they gave me 30 tablets, trying to make me become a drug dealer. I of course didn't fill that prescription, but my dentist is looking at me, and my oral surgeon is looking at me like, no, you need them. And I'm like, no, I don't. Right. And like I said, it hurt, but you just deal with it. And if adequate not received, that's when we do morphine. And that's why anesthesiologists, right, you need, for chronic pain states, you need them, because you could see how this scale here, how it can easily lead to addiction. We have a lot of our armed forces personnel. They get hurt, and they come back, with a lot of these extra addictions. And it's those of you who've never been in the military, those of you who've been in the military know you can get stuff so easy. I asked my son, he's a frontline Marine, and I go, you can still get stuff? And he goes, yeah, easy. And I'm like, wow. Some things never change. So here's some narcotics. Of course, codeine, or any of the contents like oxy, ugh, fentanyl, ugh. Hydrocodone, hydromorphine, Dilaudid. Ooh, this is all happy stuff, but there's a lot of addiction involved. Oxycodone, Demerol. You guys heard of all these, and they're just some serious stuff. And we only have that for the when as a second line drug, right? We try to give a weak opioid like Tylenol 3 or Tylenol 5 first. But if I gotta do these, but I have to monitor you. Okay. That's why they should pass the same laws that they have in New York and Chicago. In New York, I only can give you 4-day supply of this. Right? If you have severe pain states, you need to come back to my office after 3 or 4 days, because if your pain state is that bad, where I'm giving you oxy or Demerol for 4 days straight, you need to go back to the hospital, or we need to speak to pain management, because it's not helping you, right? But nowadays, what do we do? We just keep on giving it, right? Drugs to treat, and we already talked about naloxone, Narcan, right? And the overall is like patient comfort, and also I like trying to give the analgesics for when they go to sleep, so it doesn't mess with their sleep-wake cycle. A lot of my patients who have chronic pain meds and they're taking stuff like this, it throws their diurnal cycle all out of whack. Fentanyl, you could have a patch, lozenge. Now, patch is relatively local, but where we put that patch is usually next to a lovely arteriovascular supply, so it gets into your system. Lozenges are nice, and remember, a lozenge, you just put it inside your mouth, like in between your cheek and gum, or underneath your tongue, and just let it melt. Don't let the patient swallow it. That's not good. You're making the drug go through first pass effects, go through your liver, and it's going to lessen the effects. So you just ask the patient, just have it in your mouth and just let it melt. Combo drugs, we already mentioned one combo, which is Tylenol and codeine, which is really nice. And here's some other combos, nice to know, right? Oxycodone with acetaminophen, Tylox, also known as Tylenol 3, Tylenol 4, Tylenol 5, that kind of thing. Okay. Acetaminophen toxicity. You know when you need to do I had a 14-year-old girl years ago tried to overdose herself on Tylenol because it was the only thing in the house. She ate like 40 pills. Nothing really happened to her. I don't even think we pumped her stomach. Right? Refills no more 5 times. No. Maybe in Virginia, but I only refill once. Have them come back, or no refill. I need for them to talk to me. E, Not necessarily for controlled substance 4, but 2s and 3s. And remember, controlled substance 1, that's like cocaine and heroin, stuff that you can't prescribe anyway. Now, let me talk about this Phenergan, which is promethazine. Careful, careful, careful when your patient's on Phenergan. We use Phenergan for really bad GI symptoms, and to control nausea and vomiting. There are other meds that you can use, but a lot of the old school doctors use Phenergan. And a lot of patients like faking GI problems and stomach pain so they can get Phenergan. And maybe Phenergan is promethazine, right? Scissor, right? Put it in the 7-Eleven cups. But man, uh, uh, all these new cats thinking that this is something new. Nope. People have been drinking that stuff for Happy Juice for a long time. I remember the first time I was introduced to it, I was in what, 6th grade? That was what, 1982, 1981, right? So that's why I find everything old is new again, like heroin. Heroin is like the new thing. Maybe next year it'll be cocaine. We'll see. Migraine headaches. That's severe headaches, and the current hypothesis for migraine is that your neurologic, there's way too many signals going on in your head. Just imagine if all the signals of light, you were super sensitive to light, super sensitive to sound, super sensitive to touch and other stimulation, right? That's why I like telling my migraine patients, once you feel the migraine coming on, and you will have an aura, you're going to feel it coming on. There's going to be something odd that will happen. And it's the same thing for seizures. Like, for example, right before my one patient in neuro had a grand mal seizure, she started complaining at me like, he goes, why does my neighbors get blueberry pancakes? I'm smelling blueberry all day. And I didn't put it together. Next thing I know, there was no blueberry pancakes. This is Lincoln Hospital in New York City. You're lucky. I don't know. Do they even have pancakes back then in the early 2000s? I don't know. Well, she started smelling things that weren't there, right? And that's what it's called, aura. And then she had a seizure right after, right? Because remember, what controls all of your sensory? Your brain. So if it goes into overload, it's going to start, you might have some hallucinations, you might see other things, right? I had another patient said that she saw angel wings right before she used to get her really bad headaches. And the initial management, not only with medication, we tell them to get into a quiet room that's dark and just sit there. So there's no stimulation, so that your brain can have a moment to quiet down. And of course, then we start taking some meds. And this is a chronic pain state. So we have to think of sleep problems, depression, and all that other jazz. Now, another mechanism of action, and this, by the way, and this is coming from my mom's, who is she is a neuropsychiatrist. So she's not only a neurologist, psychiatrist, both A and B. She says that this is a potential. Um, um, there might be way too much blood circulating in your brain when you get migraine headaches. And that blood stimulates, of course, because blood has oxygen, has nutrients. It'll stimulate the nerves, right? Blood flow is nice up there, but too much blood flow, you'll have vasodilatation, and then that's when the headaches come. So we also might give the patient something to do some vasoconstriction, right? But again, vasoconstriction, then I'm now going to mess with your blood pressure. So it's like a give and take. So for this lecture, there are two mechanisms of action for migraine. Excessive vasodilatation of the blood vessels in your brain, that's one. And number two, excessive stimulation in the same manner that how seizures are excessive stimulation of somatic nerves, migraines are excessive stimulation of sensory nerves. Okay, so those two things combined, and those of you who have migraines know it's debilitating. Oh, look, they use the word debilitating right here, right? It'll knock you down, right? So quiet environment, lying down. We have prophylactic meds that you can give, and abortive meds, which you could take it. And PRN, not capital P, capital RN. It's lowercase PRN, right? That's abortive therapy because you want to abort or stop it in its tracks. So your patient could be having a prophylactic maintenance dose of daily, but then when something comes on, they take an extra pill, and that's the abortive therapy. Okay? And you can see here, antidepressants, anticonvulsants, calcium channel blockers, because we know calcium stimulates vasoconstriction. Beta blockers also will alleviate the vasoconstriction. Estrogens as well. NSAIDs are good. And look at this lovely SSRI, serotonin reuptake inhibitor. Now, what does that do for you? Goes, it will increase your serotonin. And serotonin, we already know, deals with dreams and sleep, right? Hold up. Is somebody stuck? Sorry about that. So we have the prophylactic therapy and the abortive therapy. And if you look at the prophylactic therapy, it's attacking the MOA, right? So, and remember that we mentioned serotonin. So if I inhibit the reuptake or the recycling of serotonin, what will I have in that synaptic gap? I'll have a ton of serotonin, right? Ton of serotonin, right, is a very, very potent antidepressant. And that's what an SSRI does. Okay. How do you know that is an SSRI? Because you have the suffix triptans. So, you know, you could try to memorize this, but it's, again, use your flashcards. But, ooh, look in red, very popular. Imitrex, very, very, very popular. And again, abortive therapy, PRN. Rizatriptan, sumatriptan, what's important? Oh, here's another one. Ergot alkaloids, that's another one. And remember when we talked about in the beginning, in the first week, we talked about pharmacognosy and about natural, how natural things like, you know, in the forest. Well, ergot alkaloids, like many, many moons ago, like, I don't know, times of, you know, knights and damsels in distress, you know, they pick weeds and whatnot from the woods, and ergot alkaloid preparations, such as ergotamine and caffeine, they work as well. And we all know that what does ergotamine and caffeine do for you? Vasoconstriction, right? Vasoconstriction, it'll work on the mechanism of action of your migraine, and it should bring you some relief. And anecdotally, some of my patients in the past, yeah, if they, you know, have their Starbucks, it kind of works out a little bit, anecdotally. But I cannot say a broad spectrum if that's true or not. Antiemetics. Okay, we also need to have that in consideration as well. Tramadol, another popular one, and we love giving it with NSAID. Drug of choice for that is ibuprofen. Let's see, what else? Acetaminophen, aspirin, caffeine, Excedrin, migraine. Again, it's an NSAID / caffeine combo, if you've ever seen this thing. But you could see the same exact idea that we talked about. synergy, antagonism. If we want to exploit a physiology of something synergistically, you make that thing happen. Or if I want to block something, I find something like an antagonist. So it is at this point of the show. Let's see if we got everything. I saw that there were no questions, but I'm going to stop the